Hello, I'm Dr. Gladman from the University of Toronto. I'm currently speaking to you from Toronto, and we're going to talk about the future of psoriatic arthritis care. I'm going to talk about four areas. First, early diagnosis, then disease assessment, outcome measures, and finally, personalized care. In terms of early diagnosis, a major need in psoriatic arthritis care has been early diagnosis. We know that up to 30% of patients with psoriasis will develop psoriatic arthritis. However, there's a big gap in making that diagnosis. In a study done in Germany in 2009, 85% of patients identified as having psoriatic arthritis by the rheumatologist had not been previously diagnosed. And in a more recent international study, in which rheumatologists evaluated consecutive psoriasis patients in dermatology clinics, 41% of the patients diagnosed with psoriatic arthritis by the rheumatologist had not been previously given the diagnosis. This is important since we know that even a 6 months delay in consultation is detrimental to outcomes in patients with psoriatic arthritis. Patients who have been referred more than 6 months after the onset of symptoms were more likely to develop damage and have more severe and advanced disability. In the future, the delay in diagnosis will be shortened. Already, dermatologists and other physicians have been paying more attention to the possibility that patients with psoriasis may have arthritis and are asking the appropriate questions. And in many instances, they also are administering a patient screening questionnaire. There are now several screening tools. Although it is not clear which one is the best, most have high sensitivity and specificity, as well as positive predictive values and negative predictive values, so that any of the screening tools should be helpful to the dermatologist to identify those people that need to be referred to a rheumatologist. Moreover, it is possible that patients with psoriasis will be able to complete these screening questionnaires online and actually self-refer. In terms of disease assessment, at present, our major tools to assess patients with psoriatic arthritis are very subjective. We're talking about tender joints, which rely on the patient's pain perception. We're talking about swollen joints, which rely on the observer's ability to detect the swelling. Dactylitis also relies on the observation of a swollen digit and determining which one is swollen. And the enthesitis measures rely on the tenderness in the enthesitis sites. Likewise, assessment of the spinal disease are relying primarily on patient-reported outcomes. However, these tools are mostly subjective and may not adequately reflect the level of disease activity. The use of ultrasound to assess disease activity is becoming more widespread and will likely become a mainstay of treatment of disease assessment in psoriatic arthritis. There are other tools that are currently being investigated, such as MRI, high-resolution CT, PET scanning, and there are other imaging modalities that will likely be further developed to assess the degree of inflammation. These will become more commonly used in clinical practice and provide more objective evidence of inflammation. This will be relevant not only to clinical practice, but obviously to clinical trials in identifying individuals that are suitable for investigation. Like the assessment of disease activity, outcome measures currently rely on subjective measures, including the actively inflamed joint count, tenderness of inflamed digits and entheses, as well as the patient-reported outcome. Pain is an important consideration here, but pain may arise from a number of mechanisms, not all related to inflammation. It is therefore important to have objective measures to assess outcome, measures to assess inflammation, measures to assess progression of damage, Even our acute phase reactants do not always reflect joint inflammation, as they may be increased due to infection or obesity. Thus, the methods outlined above to assess the disease activity will be incorporated into the outcome measures. In addition, a number of composite measures have been developed for psoriatic arthritis, which will help in the assessment of outcome of the overall disease. More importantly, biomarkers for disease activity, progression of damage, and response to therapy are being developed. And these will continue to be developed over the next few years and will become the standard of care. Those will be most important in developing approaches for personalized medicine. While some of the factors involved in the pathogenesis of psoriatic arthritis are known, including genetic, environmental, and immunological factors, the exact mechanism of disease in an individual patient is not yet known. However, the development of biomarkers for disease activity, damage progression, and response to therapy will allow us to tailor a therapeutic approach to an individual's set of biomarkers and identify the appropriate medication for each patient. This will likely start happening over the next 5 years. In summary, our ability to diagnose patients early, evaluate them properly, measure their outcomes, and develop individualized therapeutic plans for each patient will be the future for the management of psoriatic arthritis. Thank you very much for your attention.